Welcome back to another episode of the Take on Healthcare podcast. I'm Mary Sheehan, a pharmacist committed to helping you navigate the complex world of healthcare.
And I'm Ted Suzelis, a naturopathic doctor. Today we're tackling two crucial issues. First is the overuse of antibiotics, and second is when to treat a fever.
Antibiotics are often overprescribed for things like ear infections, sinusitis, and even viral illnesses. But at what cost? We're seeing a rise in antibiotic resistance and disruptions to our natural microbiomes.
We'll also look at fever management, a topic that is often misunderstood. When should you treat a fever, and when should you get out of the way and let your body do its own job?
We're very excited because Dr. Ted Suzelis, a primary care DO, will join us to share his insights on how to approach these common medical dilemmas.
This episode is packed with information that could change the way you think about your health, so stay tuned.
Let's get started.
You're listening to Take on Healthcare with Ted Suzelis and Mary Sheehan. Is it really necessary to reduce a fever when you're sick? Do antibiotics kill viruses? Don't worry if you don't know the answers. In this episode, we will explain the function of a fever and why some antibiotics are overprescribed.
I love this topic of the doctor is wrong, because you two are doctors and I'm not. So today I will be right, apparently. We're going to question common medical practices.
Yeah.
And these practices that we're questioning today obviously also affect my practice as a pharmacist. We are going to be discussing the inappropriate use, the overuse of antibiotics. And we have perfect timing because antibiotics, I don't know if you guys realize this, actually have a season now. It used to be spring, summer, winter, fall, and now we have like antibiotic season or flu shot season, right?
Right.
I call it Z-Pack season, where everybody gets a Z-Pack because...
Also known as school season.
All right. Yeah, I guess something to the fact that when people are together, infection spreads.
Right.
Definitely.
That we can all agree on.
Of course.
But what we're questioning is when and where is it right to give an antibiotic? But most, I guess, we're going to talk about where we are going wrong across the board, which isn't to say that anyone's doctor is doing anything wrong or that one should not listen to one's doctor. One always should. As always on Take on Healthcare, we're taking just a big picture perspective of a systemic problem.
Yes.
All right.
Yeah, so I think we should start this episode with antibiotics.
Yes, let's start with that.
And so I feel like we need to preface the whole episode and start at the beginning by talking about why it could be a problem that we overprescribe antibiotics. Because I don't think a lot of people really realize that.
Or what an antibiotic is. Because I've noticed, not when I was a little baby pharmacist, but now later in my career, people think an antibiotic treats a viral infection. It simply does not. Say again?
It's a definite misconception.
Okay, so you get that in your practice too. And I think that is also a systemic problem. Who perpetuated this misconception and why?
From what I've seen, I really do think that it comes down to our American society and where we want it your way right away. If we're looking at the conventional, even medical system, they really are promoting less antibiotic use. We're looking at having good practice when you actually do prescribe antibiotics. But a lot of times we don't have enough time, or we have patients that, again, we don't have the time to educate them, or we don't take the time to educate them. And then they say, I'm sick, I need this now.
Yeah.
And what do? I don't have time to fit you in the office, and you sent me a message. Should I just send it in for you? I have to get through everything else that I'm seeing, or I just want to make you happy so that I can go ahead and move on. Those are some of the things that I can see that can happen.
And also to get better patient satisfaction scores, as we talked about before.
Which is a big thing now, yes.
Which is a huge thing now. So all of these things are, to me, just blow my mind because these are, I think, real problems that can do harm to people, and yet they're so pervasive.
Right.
And I didn't know that when my first couple weeks behind the counter, when I decided to work in community pharmacy, I didn't realize how prevalent it was that people would get a virus and come and tell me, oh, I have a virus. That's why I need this amoxicillin. And I'm like, well, now I'm in a really weird place. I don't want to say, but amoxicillin won't kill a virus. So I let it go for a while. And eventually, if I got to know the doctor's prescribing habits a little bit, or I had another reason to call, maybe to clarify something, I would just say, I just have to ask you. The patient said they had a viral infection. You gave them an antibiotic. Why'd you do that? And they're like, listen, they wanted something. What do you want me to do? They wanted something. And I'm like, wow, that's exactly what you said. There's an expectation, and then you're expected to meet an expectation versus really practice good science?
I believe so. When you come to the doctor's office and you have a problem, you expect that there's a fix. And you're going to give me a drug to feel better. And I can't have any pain. I can't have any discomfort. You need to give me something right now so I'm out of that.
We see that a lot. So there's a lot of pressure. And I really understood. What was so interesting to me, for me in that moment, was I really understood the doctor's perspective. I didn't know they were feeling that kind of pressure because I thought they just stood on science. They would like literally say to the person, well, no, you have a virus. Of course, I'm not going to give you an antibiotic.
Right.
And that was not the case. So then what happens then? So you think you're listening. So what's the big deal? So what? I get an antibiotic. So what? They feel better. I feel better. The pharmacy makes 50 cents on a generic amoxicillin. Everyone wins. So what's the harm?
Right. Well, that's what we need to talk
So
about.
what's the harm? There's two harms. I think it's individually, but there's also a collective harm too.
Yeah, definitely. I would say number one is that antibiotics have side effects.
They do?
It's shocking, huh? Yeah, things like killing off the good bacteria.
Which now we acknowledge, which we didn't back in the day.
Right. And you can get a lot of normal symptoms because of that, killing off the probiotics, things like diarrhea, abdominal pain, nausea, vomiting.
We have drugs for that.
Right. Give another drug to counteract the side effects of the antibiotics. Yeah, perfect. But then we have things like allergic reactions.
Well, that's very true too.
Yeah, still you have
It
your
still
fair
happens.
amount, rashes, itching, even anaphylaxis.
Or that rare thing like with the quinolones. Like I can't tell you how many patients have the rupture of their Achilles tendon.
Oh, yes, the weakness of the
Yeah, especially when combined with a steroid. It increases the risk, and people just didn't know that.
Right.
And that can happen, and that's pretty serious.
Oh, definitely.
Yeah.
It's not like that has become a big educational campaign, like be really careful in case you're one of the rare cases that get something rare.
Right. Yeah. Cipro shouldn't be your first line of defense for a urinary tract infection.
Correct, but sometimes it is.
Right. And that's the thing. There are definitely lots of bigger types of side effects that different antibiotics could have that could be dangerous.
But I think you made it when you said like the GI side effects, you get some diarrhea. I don't think people really think that's a big deal. And in fact, one person said to me, she was put on 4 different antibiotics. So anaerobic, aerobic, it was quite the gambit. And she's like, so I didn't pick up that other one that I'll need for the yeast infection. So it's almost also like it's no big deal. Right. So what?
Right.
Then I just need one more drug, a fluconazole for a yeast infection. What's the big deal? Right. But if all of these things, like a yeast infection or diarrhea, the GI things are symptoms of killing off your good gut flora,
Right.
do people even understand why? Like, so what? Do I really need those guys?
Certainly do.
Right. But I
Yeah.
think that, do traditional doctors understand? Ian, do you guys understand about the good gut flora? Do your peers understand that?
Yes. Yeah.
Okay.
I think that especially now, since we have so much research, we do see that. And it's something that we're encouraged in all the time as far as different medical journals or articles that the gut microbiome is so important. And we look at that even when we're talking about the diarrhea. So one of the big things, so we give an antibiotic, somebody gets C. diff. We understand that C. diff was in there. You killed off a lot of the other bacteria. You let this one promote and grow.
Right.
And so we have this idea and we know that this is something. And we also are encouraged to go ahead and talk to people about taking in cultured foods, probiotics, things of that sort.
Oh, very good. So, which is a big change, I think, over the past 30 years.
It definitely is.
About to the C. diff, is there data that suggests that some are more prone to it, or data that says if you've had a lot of antibiotics as a child or a young person, that down the road you're going to be more likely to get C. diff? What do we really know about its frequency, or who can get it and who won't get it?
I probably can't speak to that one as far as the research, but just thinking about it, yeah, you do see people who have been treated with multiple antibiotics. Those are the ones who end up typically getting C. diff.
Which is very serious, can be very serious, and sometimes hard to eradicate.
Yes.
Right.
So then we're thinking down the road, maybe that's something that people can think of future self, right? Like, so what? I kill the good guys this month, and then maybe in 3 months. But that over time to the same individual could really weaken. And if we're just finding out about this now, we don't know what the next 20 years will bring. Hopefully more research for sure. But yeah, it would be something to think about. I even forgot about C. diff.
Yeah, so along that line of the C. diff, we typically think about it with hospital infections. So
Yeah.
I just wonder what the frequency is. That doesn't seem to be one of our normal gut flora. So maybe it is people contract it in the hospital, whether they're visiting or in the hospital. And then when they have the antibiotics, it kills off the good bacteria and allows it to grow.
That's definitely a possibility there too. I would agree.
And we all know now that our gut is part of our immune system.
Yes.
So then it seems a little bit ironic, right?
Yes.
And it's a sad story that
Definitely.
we're inadvertently, unwillingly killing the thing that will help us the next time, right?
Yeah.
And this time.
And I can't tell you how much I've observed, and I'm sure you have too, to a degree, when you have families that are much more natural minded, that they don't always go out and dole out the antibiotics like our family,
Right.
that people tend to fight infections a lot better and never really need those antibiotics down the road.
I do see that. Yes,
Ah.
definitely. You see especially we'll say children or even adults that are needing the antibiotics or needing the antibiotics. They are the ones that keep on coming back. And yes, they have the ear infections again, or they have the sinus infections again, or they're dealing with these different things over and over and the side effects of them. I need another, hey, you're giving me an antibiotic, like you'd said, go ahead and send the diflucan in as well, because I'm
Right.
going to go ahead and have a yeast infection.
Right.
Mhm.
It becomes an expectation.
Right. Yeah, the kids with the chronic strep infections that you can't get rid of no matter what.
Yes.
Really? Meaning antibiotic after antibiotic after antibiotic. Oh,
Yeah,
that
and
was
then
my son.
these kids just keep developing strep infections one after another.
Wow. So then how would like a natural approach be to that? Because that scares people. Like when my
Right.
son, that's how I found alternative medicine, interestingly.
Mhm.
My son kept getting recurrent scarlet fever, which is a strep infection that shows up on the skin. So it's very terrifying. The fever's high, the skin's red, and it was antibiotic after antibiotic, and he kept getting allergic to them to the point where the doctor said, well, the next time it'll be IV vancomycin in the hospital. And I'm like, nah. Well, let's take out his tonsils. I'm like, do we really want to be ripping out body parts? Now we don't. But 30
Yeah.
years ago, we did take out the tonsils a lot. And now we don't do it. And so I did it because I am a good soldier of the American healthcare system. And then he got infected again. And I said, but you said this wouldn't happen again if I took out his tonsils.
Right.
And that's when I'm like, I am abandoning this system quietly, so no one knows, and finding alternative medicine because this is crazy.
Mm-hmm.
So what would be if you had a kid that had these chronic infections, what would be another approach to it potentially?
Okay. So first off, we're looking at the immune system. Overall.
Imagine. Okay.
So 60-70% of your immune system is in the gut, which of course that goes along with a lot with those probiotic cultures, but also just your own immune cells. And we have this tube from our mouth to our anus that allows infections in. We got to make sure that we can kill them off. It's not as bad on the skin.
It was a good strategy, actually. If you were making the human body,
right.
You do that too. Yeah.
Of course. So with that, we have to look at all these different factors to help get that gut healthy, to help with the immune system. So one of the big factors I always start with is a healthy diet, eliminating foods that may be having sensitivities that is taxing your immune system so that you keep fighting the foods you're eating and it doesn't allow you to fight the infection as well.
God, I love that. Because I don't think that connection is easily made.
No. And then if we need to repopulate those gut bacteria or do other nutrients to strengthen that digestive tract, and then we can look at different natural therapies to support and strengthen the immune system to fight those infections too.
Okay.
And a lot of the natural strategies is more, a lot of the herbs and nutrients are more to strengthen the immune system to fight the infection versus just directly killing it. There's certain things like oregano oil and garlic and colloidal silver, different things that would directly kill the infection, but a lot of naturopathic natural therapies are based on supporting the immune system to overcome and fight the infection.
I think that's such a great distinction between fighting the infection naturally or chemically from a drug versus strengthening the immune system.
Right.
Although I think at home I've used oregano oil back in the day for something.
Yeah. And there's nothing wrong with that. I'll use that definitely a lot. And we'll use some of those.
Because it won't kill the gut bacteria. But how does the oregano oil not know not to kill the gut bacteria? And the amoxicillin doesn't know.
Well, like say oregano and garlic, these are normal parts of our diet.
Oh, yes.
So
of
the
course.
good
I
gut
never thought of that.
bacteria are resistant to their effects.
Isn't that amazing?
Yeah.
The connection between nature and humans.
Right. That symbiosis.
Yes. I love that. And I think that's such a great reminder of how it all leads to the gut,
Yes.
right?
Yes.
Well, then, Anne, how about it like in your practice? Do you, because you're a DO and not an ND, when somebody comes to you with, say, the example of a recurrent strep, do you go down that road too, or you don't because it's not in your model, like your practice model?
Whenever I approach it, it's on a patient basis and looking at them and just seeing where are they at, what are they willing to do, number one, because my whole goal when I talk to them is about their health and trying to make sure their well-being is good overall. And I'm also looking at it from a perspective of what have we learned through studies and conventionally, what is my kind of pathway that I'm going to take. So if I have a patient that I know will work with things, I'm going to work with them with the natural route. I'm going to incorporate my brother over here and helping out as well. But if I need to, as far as they're not somebody that's going to follow the regimen that we need to try and get them healthy from that perspective, I'm going to make sure that they're safe at least.
Yes, of course. Yes. Again, a great point.
Yeah. Where I have the luxury of they're coming to me specifically for the natural side of things because they're trying to get away from those antibiotics.
Right, exactly. So it's not that anyone here at this table is promoting just, woo, let it ride. Like
Right.
any intervention, you listen to your doctor and you guys both meet people where they are, which I think is a great approach. And speaking of the infections that we're going to see a lot of, we use strep as an example, but I'd really like to get into ear infections because it's always been like this thing with me since my kids were little, and like, how do you really know it's an infection? And I would never give them antibiotics for infections, which 30 years ago, that was like, you could never, like, how dare you? I had my other ways of doing things, but I think at that point, even there was something, the journal Pediatric Medicine came out and said they're really not effective. And I think a lot of it has to do with vasculature, right? Like there's not a lot of vasculature there. So is the antibiotic even getting in there? And then I've seen lately that now we give steroids on top of it because there's so much swelling that the antibiotic's not getting there. What do we think about how the ear infections are overall being diagnosed? Because I think that's changed. And what does that mean?
What I look at whenever I'm looking at it, I try and follow the guidelines as well. So if we're looking at, we have to distinguish then between acute otitis media, and I think we were talking about otitis media with effusion, looking at the different variabilities here. But of course—
What does that mean, just for like the layperson? So acute otitis media versus one with effusion.
Okay, so with acute otitis media, we are looking at an acute infection, and if I'm looking in the ear with an otoscope, I usually see a bulging, very red, sometimes with pus behind it, tympanic membrane or the eardrum, and the patient is going to have other symptoms: ear pain. They can have a fever,
but they don't have to have a fever, right?
Oh,
fever,
they don't. No,
right?
they don't have
sometimes
to.
They do,
I mean,
and sometimes they don't,
see,
which is weird to me. But
exactly, seeing those different signs are things that are going to lead me to say, okay, are we dealing with an ear infection? as far as an acute otitis media. And then we're looking at time frame as well. And we're looking at age. There's a couple of different things there. We're looking at definitely younger children. We are going to, especially 6 months or less, we're paying more attention to what they're dealing with. And we know the different bacteria that are the main culprits there. And that's why we're looking at specific antibiotics, particularly amoxicillin to start out with. But that's whenever we would base it off of those different symptoms. Usually 48 hours is what we're looking at, that they've had them and they have those different symptoms before we'd say, yes, we need to treat. So, or a temperature, I think either a temperature of 102, you're also paying attention to that if you see that there's a higher temperature with it, along with the signs that you're seeing in the ear. That would indicate an acute otitis media. Versus otitis media with an effusion, we have fluid in the ear, but we don't have that bulging. Usually it's going to be retracted. Usually there may be sometimes you'll see bubbles behind the ear. So it's not, you don't see the infectious process, that redness, the pus, the inflammation that's occurring because the body is attacking something.
So that's a great distinction. So there could be inflammation because the body's attacking something, and there could be inflammation for a different reason.
Yeah.
And to the patient, these things probably feel similar.
They do. And this is where we have to try and make the distinction.
Yeah.
But a lot of times this otitis media with effusion is going to occur after an ear infection. So they've had this, they have some eustachian tube dysfunction, or that tube that goes between the sinuses and the inner ear there. Sometimes it gets blocked up with mucus, or we have that pressure in there and it keeps the ears from draining. So then we have this fluid that kind of stays in there. And it can happen after infection. The infection's cleared, but this fluid can stay in there for 4 to 6 weeks, we'll say.
Wow.
That's typically what we're going to do. And a lot of times, being an osteopath, I'll work with it in a couple other ways. But
Like manipulation.
Yeah, manipulation
That's
as
what
well.
I used to do for my kids' ear infections, just have some manipulation done.
Yeah, helping things to drain, helping blood flow, lymphatics.
Yes, that's what I would do. And it's 30 years later, and I'm like afraid to admit it. But yeah, we didn't have a DO at the time, but so you still actively do things like that to help support the body.
Yeah, that's a big part of my practice that I really enjoy.
Yeah, I can see why. And have you found that you can, like, my kids could clear out an ear infection with just a few manipulations? Are you finding that to be?
Yes, used to. I don't as much now because it's like I can't follow up with patients as much. So I'm trying to give, what I really desire is to try and help families to know how to do some different manipulation, or even like auto-inflation, where you plug your nose, plug your mouth, and lightly blow to help open up the eustachian tube so it can drain better. Massaging in front of the ears, or doing some ear tugging as well.
We used to teach our kids that too. Yeah.
So different things we can do to help out, and then teach families, because ultimately the family is going to have to, they're taking care of their child, the parent is. And that's, if we're talking about this particular issue, even adults, when we're dealing with the ear infections or the fluid behind the ears, they can do some of these things on their own to help out.
I've seen a big uptick in adult ear infections over the past couple of years. Are they really infections? How are adults getting ear infections? And isn't part of the reason kids get ear infections, isn't it a structural thing with just how their little faces are and the tubes that you were describing?
Yes,
with the very
that's why it's a lot more common.
Okay, it's a structural thing. It's
right.
Okay.
Yeah, when you have a much more small and narrow canal that's already small and narrow for adults.
And you want it to go in there and clean stuff out. It's harder. Okay.
But yeah, as far as the adults, a lot of the times, I can't tell you how often I hear patients that came from their medical doctor and they looked in their ears. Oh, you have double ear infection. You need a Z-Pack
too.
And they're like, oh, I didn't even know I had one.
So what's the diagnosis based on then? If it's clearly not fever and pain, or they would know they had one.
Right.
So what are we basing this diagnosis on? What are we seeing in there when we look in there? And why are we looking in there? Like, it's not very common for an adult to have an ear infection. Well, now it is, but
right.
Well, they were coming in originally with some other complaints. I got a lot of sinus congestion, or have a sore throat.
Okay.
Right. Yeah. And so I'm going through and doing my exam, and I'm looking, and I'm not saying that this is me looking in there. Oh, you don't have any pain. Oh, yeah, I see a little bit of redness on that tympanic membrane. Again, I'm looking at it and saying, well, I'll say a couple different things. Number one, yes, the patient may have been expecting things. Number two, I'm trying to decrease any kind of litigation.
Yeah.
And number three, well, I'm going to make sure that I don't miss something.
And I see it more often with patients that are going to a new doctor and doing their initial physical. So this doctor is trying to show what a good doctor they are.
Yeah.
And so, oh, you have a double ear infection. We need to treat that right away.
Yeah. I see it a lot with urgent cares. They're running through, and so they see, oh, yeah. It looks like you have an ear infection, double ear infection. Let's give you the antibiotic, give you some steroids, send you on your way.
Lots of steroids, too. That's a whole other episode.
That is.
Right.
And viruses can cause ear infections.
Of course. Yeah.
How on earth would you know if it's a virus or a bacteria? Neither one of them is in there identifying themselves with.
Right.
So how do you guys know which is which? And again, an antibiotic does not kill a virus. So how do you know?
So again, I'm looking at it from a perspective of I'm looking in the ear and I'm seeing these different signs, physical signs, as well as their symptoms.
So the viral and a bacterial present differently?
Again, when we're talking about, I'm not going to see a virus that's going to have this bulging eardrum that's red with pus.
Oh,
so that's one of the distinguishing things. And when we're seeing that, we're usually looking at it and saying, yeah, this is a
bacteria.
60% of them are going to be bacteria when we're talking about true ear infections. And when did they occur? They usually occurred after I had a virus.
Right.
I had a lot of mucus in my sinuses. It's blocked up, how things are normally draining. The bacteria had a chance to grow. So it's one of those things that occurs over time versus acutely. Yeah, all of a sudden, bam, I have a bacterial infection in my ears and it just happened overnight.
No, it didn't.
And that's where a lot of doctors will just prescribe the antibiotic because
they think it's going there anyway.
It's going there anyway. Let's just cut our losses and get on with the treatment early.
Plus, like you said, everyone's so busy. So if I've seen this 1,000 times before as a doctor,
I know it's going to
let's
happen.
just give them the antibiotic because they're not going to be able to fit in. Everyone's so sick right now. So they just do it. It makes sense from a certain perspective.
Right. But when we're talking about causes too, a lot of what I see is that it's an allergic response. That the eustachian tube dysfunction is mostly that people are having food sensitivities that are causing inflammation in their ears and their sinuses that increases their likelihood of getting an ear infection.
Yes.
Oh, see, that's, again, lines that even I know about this stuff, and it was hard for me to imagine. I think we understand, like, if my nose is running, it could be, do we? Maybe we don't. That we have a food allergy.
Right. Yeah.
I don't think
that's
people
part of what we need to talk about here too. Yes.
Yeah.
Yes.
Yeah. I was at lunch the other day at a new job, and the one, every time we order pizza, every time the kid's like, yeah, every time after I eat, my nose gets stuffed and my eyes water. So there's a connection being made, and I immediately, it's every time we have pizza. So is it a gluten allergy? Is it a dairy allergy? He'd have to figure that out. But that would be something that after every time you ate something, you had some sort of response, like even being tired. That's how I figured out a lot of my stuff. Why am I exhausted? Something doesn't agree. Like to even train people to start thinking along those lines.
Well, but it can be difficult to connect to those dots too, because I find that when people react to a food with a food sensitivity versus an allergy, so the allergy is very immediate, very strong.
There's a difference,
and you'll work through it quicker. The food sensitivities they may be a little delayed, up to 24 hours, but they're going to last for 3 to 5 days plus. So you could have that reaction for several days, or say you're eating some level of, say you're sensitive to dairy and you're eating some level of dairy every day.
Yes.
So you're not always noticing that because your immune system can't have that strong response all the time.
Very great point. Or you eat something weird and automatically then you're aware of the symptoms that have been going on and you're connecting dots, because we love to do that as people, right? Right. I drank out of the wrong cup. That's why I'm sick. We like to make those associations. We're very superstitious.
Yeah.
Oh, that's so interesting. So that's how overall it could present. Not only could it present as an infection when it's not, these like underlying flared up reactions to food, but I'm also hearing you say that your immune system is being taxed anyway. So then with the constant fighting of the food, like you said earlier, that would make you more vulnerable.
Definitely.
Once again, all roads lead to the gut.
Right. So when we look at that, we have all these different causes of those ear infections. My take and what I see with my patients is that the allergy and sensitivity issues tend to be a big underlying piece of that, which allows the infections to happen when they do. Part of my treatment's always going to be working on those food sensitivities to help reduce that inflammation,
Yes,
to help them
inflammation.
stop and break this cycle.
Mm-hmm. That makes perfect sense.
And then it moves right on to the other part of this, which is the sinus infections.
Yes. I've seen so many more of those. And in fact, like being at a more recent community job I had over so many years, I could actually see a few patients that just looking at their profile, chronic sinus, and now all of a sudden there's a fungal infection in their sinuses. And that's surgery. A lot of times they'll try a few courses of heavy duty. We don't think it's a big deal. Like, okay, so what? It's a course of antibiotics and we forget. And 3 months
Right.
later, so what? It's a course of antibiotics. And then before you know it, you can really end up with resistance to the point where you have fungus growing in your sinuses.
Yep.
Have you seen that?
I have. I've seen several cases of that where they've been treated over and over and over, and it just keeps recurring. And then whenever they end up having a swab and they check to see what's growing in there, you have the fungus that ends up showing up.
My God. Yeah, that's frightening. So do you think then, is it possible, like when I think of like something so deep as a sinus infection, is it possible that as we're treating it, we're really never quite fully eradicating it? So that the bugs that are in there that, like I've seen amoxicillin before, cephalosporin, all right, see what you got. Whatever. Like they kind of just get stronger and stronger till eventually nothing kills them? Or what happens with that? Or is it an overall weakening? So the body gets overcome with fungus. To me, that seems like such a big deal.
Mm-hmm.
I'm more horrified when somebody tells me they have a fungal sinus infection than they are.
A lot of times I'd say you're correct. I don't think they're as concerned or understand it as much. But again, it's just like we talked about with the gut. We give these antibiotics over and over. We go to stronger ones because it's not controlling the symptoms of a chronic sinusitis, which is different than an acute sinusitis.
Okay, that's fair. Yeah.
But so they keep on treating. They got to go higher. Okay, well, that didn't work for me. I'm still having problems. I still have pain. All right, here's the next level up. We're going to keep on escalating because I treated you for the main bugs that we would normally see in there. Mm-hmm. It's not hitting it. So I keep on going up. And then we have this killing of so much of the flora that, of course, we have talking about, the mouth on down. Well, that nasal passage is connected as well. And so we have those different bacteria in there. And so if we kill those, hey, guess what? That leaves room for fungus to grow.
Wow.
And of course, the number one that we see lots is the candidiasis.
Yes.
Yeah.
I would agree.
So you have that candida fungus.
I didn't even think about that. Yeah.
Right. Which is obviously that's one of the biggest things you see with antibiotic overuse. You get the thrush, or women will get the vaginal yeast infections. But after all of those antibiotics and eating way too much sugar too, it'll help that fungus, that candida fungus, to grow throughout the digestive tract. And then you can get it in the sinuses too.
I've just seen so many sinus infections over time. That could be allergy as well.
Right. And a lot of the time it is.
Yeah.
Yeah, it's really complicated. I think a lot of times we think that it's clear cut when we say allergy, virus, bacteria.
Sure. Straight line is a straight line.
We should know which one is which.
Yeah,
They're all
exactly,
different.
yeah.
Right. But it is not. I mean, when we're looking at it, a lot of times there's a lot of overlapping symptoms that present.
Right.
So how do we know what to treat and when to treat?
Yeah.
That is such a great point.
Even including what the mucus looks like too.
Yes.
Yeah, we're taught that green mucus means a bacterial
Can
infection.
we talk about that? Is that 100%?
That is definitely not 100%.
No.
And when we're looking at it,
I've been lied to.
what is when we talk about these different colors is in the mucus, we're looking at our own cells. These are our own cells that are giving the color. This is our body's, again, the inflammation. Our body is coming over there to fight something off, whether it be an allergen, whether it be a bacteria, whether it be a virus, but that's what's causing the color. And it does not always mean a bacterial infection,
right?
I shouldn't say everybody, there's a lot of people that do. They persist that and say, hey, I got a little bit of yellow in my mucus now. It was clear. I think I need an antibiotic.
Yes, I've heard that too.
Yeah.
That's why I needed the antibiotic. And that's not, that straight line is...
That is not.
Superstition.
That is.
Wow.
Misinformation.
Very interesting. And these kinds of misinformation that are so linked to, but I need something to feel better. And here's the evidence for it.
Right.
It's really, I think, hard to uncouple that. And there's just so much marketing toward it. Like, yes. I don't know how anybody competes with the marketing. And to me, it like with you, it comes down to the gut.
Right.
With me, it comes down to the marketing as like this big force that we're all up against that has nothing to do with science. Well, it does because it's psychology, which I guess is kind of a science. But yeah, what else do we want to say about the sinus infections? Anything else? As we approach Z-Pack season and bronchitis, what about bronchitis? Like if somebody has, well, let me ask you this. Okay, back to mucus. When we're coughing something up or blowing something out, the blowing something out comes from in here, right? It's our own cells that are just responding to inflammation. But if we're coughing something up, that really freaks people out. So where that's from the lungs. Why would lungs ever have mucus in them? Just from inflammation, right?
Well, we're secreting mucus all the time over in our lungs.
We are?
It is part of our natural defense so that we can go ahead and catch different things, whether it be viruses or bacteria.
Care of it.
And we have, what are they called? The cilia, the little cells in there, the hair cells that go ahead and help to get it up and out. So then we can go ahead and cough out the loogie. Right. But yeah, so going back and we'll lump these both together as far as sinus, acute sinus infections, we'll say viral, and bronchitis. For both of them, we're looking at over 80% of them are viral. We're looking at it. I'm actually going to say
80%
over 90%
of sinus infections are viral.
Actually, we're looking at probably about, when this starts out, we're probably looking at about 98% of them are viral to start out.
My gosh.
If we're looking
to
at
start out, but then they sometimes get a pseudo, like another infection on top of it.
Again, we can have a secondary infection.
Yeah.
But the bronchitis, that's the same thing. And everybody thinks, I'm coughing something up. I had this in my nose, and now it's getting into my chest.
Yes, that's
it's going to my chest.
Mm-hmm. And
so I need
that
to do
is interpreted as a disaster.
Right.
Yes. Nobody wants pneumonia. That's serious.
Viral or bacterial.
Right. So that's whenever they start to say, okay, it's coming into my chest. Mm-hmm. But again, we're looking at bronchitis is going to be over 90% viral. 90% of them. Wow. And then we come to time frame as well, and we're looking at time frame. How long should bronchitis last? How long should a cough last? How long should acute rhinosinusitis last?
Please answer that question. 5 minutes. That's my tolerance.
Exactly.
As an American woman, 5 minutes.
So truthfully, we're looking at a bronchitis. We're looking at 4 to 6 weeks. And you're going to have that cough that lasts afterwards.
Should we just settle into that reality? Is that what you're suggesting?
Well, but even with COVID, people can have months and months of that immune reaction.
Which is a virus. Let's remind everybody. Yeah.
Yes.
Okay. So that really does make a lot of sense that it could last a long time.
Yeah.
And we just don't like that.
Right.
No, my cough's lingering. I'm sick of dealing with it, and I want to get rid of it.
And then they get an antibiotic. Mm-hmm. And sometimes their coughs go away.
Well, one of the things about antibiotics, and this is why I think also we see that people say, oh, I got relief when I took this antibiotic, is because it's anti-inflammatory sometimes. We see that it does decrease some of the inflammation. And again, we go back to inflammation. What is inflammation? It's our own cells getting in there and fighting off something. So we've decreased our body from having to go and do the work. Really, that's what it comes down to.
Or is it just placebo?
Both.
There may be some placebo too. Yes.
Yeah. Right. And didn't they show that a Z-Pack, the azithromycin, they have shown some anti-inflammatory action with that?
Yes, they have. So a lot of them, like I said, the antibiotics, a lot of them have anti-inflammatory.
Fascinating. So that's part of the relief too.
Mm-hmm. Yeah, but I think it's probably good for us to step back a little bit and talk more about the mucus.
Yeah.
Because yes, we have immune cells, secretory IgA, that specifically helps to produce that mucus because that's part of your immune system fighting those bugs.
Yes.
So it's not our enemy.
No, the mucus, if it gets too thick and it blocks your lungs and you can't breathe, and
then it's an enemy. Right.
Exactly.
But just not because it exists.
Correct.
But there's a very compelling TV commercial that would say otherwise. I'm just saying. Where the mucus is personified and it's your enemy. And again, I just think that is so amazing how a marketing campaign could actually change people's perceptions of their own bodies and make part of your natural process an enemy when it's really a friend.
Correct.
Like a fever, but we're not ready for that.
No, we're not ready for that.
We're not ready for that. Okay, so back to the mucus. Continue on with your with singing the praises of the mucus.
I just wanted to make that specific point.
Yeah, that's a great point.
That is specifically part of our immune system.
So
we
have
immune cells that produce
freak out.
Right. Because if we couldn't produce that mucus,
we'd all be dead.
Right. There are some people that have a deficiency in that secretory IgA, and their immune system can't fight off these infections.
Mm-hmm. The gut flora, the mucus, all part of the immune system. Okay. So where does that bring us? Where do you go from mucus, really? That's such a high. Where do you go?
Well, yeah. So when we're talking about that mucus and trying to keep it thinner,
Water's a good help.
water is definitely a good help.
Number one mucolytic.
What did you say, Ian?
I said this is the number one mucolytic as
I
far
know.
as breaking up mucus.
Yes. When the people get the antibiotic for the probably viral bronchitis, and my doctor told me to get guafenicin, which thins the mucus, but it's all of a sudden it's got dextromethorphan in it, it's got Tylenol in it, it's got this in it and that in it, just to find a straight up bottle of guafenicin. And I always tell people you have to drink water with it. Why? Because you have to.
Mm-hmm.
That's what you have to do.
Right.
Because I'm just trying to sneak in another
Yeah.
mucolytic, right?
Yep.
But then you also have the number one dietary supplement since COVID started, which is N-acetylcysteine, which breaks up mucus.
That's true.
Of course, even medical doctors know that, and you can get
Yeah. I mean, as
mucus
far
mist.
as, using that in the hospitals and stuff to help break up mucus along with your nebulizer. So that's something that they've used for years.
Years, yes.
So we can do it orally too,
Exactly.
and it can help to break up that mucus, keep it thinner, so that your body can still fight everything off, but not have it be so thick that you can't breathe.
Right. Or that you
Yes.
feel like the choking all the time,
Right,
which is
right.
not comfortable at all. So then you would just do the supplement, the NAC supplement. And yeah, we can buy that.
Yeah.
Like vitamin C, really.
Yep. Like I said, it's since the early on in COVID, the supplement companies, every supplement company I've talked to, that's their number one seller at this point for the last 4 years.
That's
Wow.
amazing. That's really cool.
Yeah.
It's good because it's pretty safe
Yeah.
and it does do what it's supposed to do, which is thin
Right.
mucus and doesn't
Right.
mess up anything else.
Well, it has other benefits too, because it also is good for the liver. It's one of those detox nutrients for the liver.
That's right. I forgot about
'Cause
that.
when the Tylenol
That's
overdose
how,
and stuff.
yes, that's how I used to know it as a little baby
Right.
pharmacist at Metro Health Medical Center. All the Tylenol overdoses were happening then. We're going way back, and would give the N-acetylcysteine, and the nurses would open it carefully, put it in with a soda or whatever, put the lid on it because this was sulfur
Right.
smelling, and people would drink it to save their liver. Yes.
Yep. It all comes full circle.
It does, doesn't it? Wow. No, that's a good one. We'll have to make sure that we have that in our little supplement section at our pharmacy to make sure we have that for people.
Yeah. And I think one more topic that we really need to cover for the whole antibiotic overuse is one of probably the biggest societal issues with overuse of antibiotics, which is antibiotic resistance.
Yes, that is a great topic. And we remember MRSA
Correct.
back in the day when it was just running rampant in many countries. And there were certain countries that were able to get a hold of it really quickly because they had socialized medicine. And there was one payer, not 1,000 payers. And that one payer, the government said, listen, doctors, I pay you, and I, your government, say you shall no longer give antibiotics for viral infections. And they said, all right. And they stopped doing it. And when they saw a big change in that.
Right.
Whereas America during that time still suffered from a lot of MRSA.
Prescription rates
Oh.
in the Netherlands.
Yes,
So
yes.
with the pediatric ear
And they
infections.
have socialized medicine, correct?
Correct.
Yes. Okay.
Yeah. So with here in the U.S., prescription rate for ear infections is 80 to 90%, where in the Netherlands it's like 31%.
Wow.
Because
That's a huge
they're being
difference.
much more judicial about prescribing antibiotics for what their true intention is.
Right. And that's how you prevent resistance
Right.
over time. And that really will affect all of us. As the bodies grow these bugs that are resistant, they get smart, and then we spread them around to each other, and it's a very bad thing.
Yeah. So do you want to do an overview on antibiotic resistance?
Where are we now with it? Like, what's happening? What are you seeing in practice now?
You know what?
Or what are your CE people teaching you about it?
Oh, as far as antibiotic resistance in general, yeah.
Yeah.
No, we're definitely still being very selective with antibiotics.
Okay.
We're trying to avoid several different antibiotics if you don't need them. Like you talked about with the quinolones, trying to make sure. And I think one of the things that we should be looking at as far as physicians, over at your hospital or in your area, they usually have like a biome card, or I'm trying to remember the name of the card specifically.
Yes, we used to carry those around with us at Metro in our little lab coats. So
to tell
we
us
knew
exactly what
yes, the rates are.
Exactly, the
in
rates.
the community.
So we know, and that can help us in knowing how to prescribe, because I think there's
Yes.
also a misconception when we're talking about lay people about knowing what antibiotics treat what bacteria or what's most common. And so I think a lot of times an antibiotic treats everything.
No, it doesn't.
But yeah, so as far as the antibiotic resistance, yes, we're still talking about it. It's still something that that antibiotic stewardship is really being promoted more and more now. And especially, again, as we're looking at the gut microbiome. So that's really where I see it right now. We're still trying. We're trying to encourage people. We're trying to make sure that it is in education.
Yeah, so I think we also, because we're talking to the general public here, and both of you are kind of losing sight of, most people don't know what antibiotic resistance really is and understand it.
Take us back there, Ted.
So antibiotic resistance is where we're giving lots of different antibiotics
Over time.
like we're talking about overprescribing them. And so you never fully kill off that strain of bacteria. But the strains that are left are more resistant to that antibiotic. So you keep giving that antibiotic over time, and it's less and less effective because the bacteria strains, they change their DNA. So the ones that are more resistant, they're the ones that keep growing more and are less effective to that antibiotic. And so that's what we're seeing overall, is that these antibiotics are being prescribed too much. And another piece of it is, too, that patients aren't taking their full course of the antibiotic either. They take one or two pills, they start to feel better, and then they stop it.
Right.
And so they only kill the very most susceptible strains, and the rest is left to keep growing.
Yeah, it's a great point, because I don't think people realize that part of nature, bacteria, how they also want to survive.
Right.
They have their own mechanisms.
It's any kind of evolution that we're looking at, that we all want to, it's survival of the fittest. We all want to survive, and our genetics make it so that the best and strongest can keep going.
It's a great analogy. And it reminds me, as we approach fall, aka Z-Pack season, the Z-Pack, I feel like they've kind of have a great marketing edge in that it's however many days, and it's quick and easy, and it comes in a little pack, versus, I don't know, a bottle of amoxicillin. It just loses its glamour after day 3. But a Z-Pack, man, right, to remind people to finish it even if you feel better.
Yeah.
But that's the words. Finish it. All right.
Right.
Finish it even if you feel better. You have to remind them, because then that's respect for the antibiotic, at least. Like, if you're gonna do it, I don't care what it is, but if you're going to do a medical intervention, do it with your whole being and do it right. Use the placebo response, be happy about it, and do it to the end, right?
Yeah.
That will be my messaging. I'm going to put on a little production with every Z-Pack.
Yeah.
You can see it, right?
One of the supplement companies is now putting out a little pack, immune pack, a 10-day pack to help fight infections.
They're stealing from the Z-Pack people, because it is very cool.
Right.
Isn't that a cool thing?
That really
I'm on a
is.
Z-Pack. I'm on a course of antibiotics called amoxicillin.
Right.
Who cares? Z-Pack. Wow.
You want to be one of the cool kids.
You know, when I say these things to my kids, because we don't do this stuff at home, and I say, what's that? I want that. Yes, who doesn't? It sounds like it makes you stronger and faster, right? That's the idea. That's what they call it, that. And it has the letter Z in it because all of the new drugs have a Z or a Q or an X. They're just much sexier. So what is the name of this new immune pack? Do we know?
I don't even
Well, it
remember.
better be something sexy. Yeah. No, it's such a great point. I think that kind of education for people, just an understanding that antibiotics or bacteria do want to live and survive as well.
Right.
They have their ways. That's why we have like outbreaks of MRSA, which I probably should have defined as methicillin resistant, Streptococcus aureus, which that used to be, or is it staph?
Staph.
Thank you. Staph. Staph infections used to be so easy to clear up, right? And then all of a sudden we had this one.
Right.
It always worked. The
Right.
antibiotics always worked. And now it's like, nope, I'm smarter than you now. So we do have to think about that.
The drug industry now is pressured to try to keep finding new antibiotics that are going to help fight these resistant bacteria.
Yeah.
And so it's a continuing factor that because we're abusing the antibiotics, we're becoming more and more resistant.
It's
so
true.
they have to find better and better antibiotics so that they can kill these superbugs so they don't kill all of us.
That's right. And those antibiotics are brand and they're expensive and they're
Right.
going to be limited and they're going to be a prior authorization and it becomes a whole thing.
Yeah.
They're so expensive. And by the time that those get to generic, and some of them don't because they're cause too many deaths and side effects and interactions. So the fancier we get with this stuff, right?
Right.
We have to think about that too. The more powerful they get, oftentimes the more dangerous they become.
Right.
Right.
But you're always looking at that risk to benefit ratio. If you
Sure.
have an infection that you're going to die from, well, let's
Oh.
take the risk of damaging our liver to kill the infection.
Absolutely. I'd make that choice.
Right.
But I would hope that my body would never get to that point.
Yeah.
That I either couldn't fight it anymore, or I would hope it would never get to that point, or there would be something that we've collectively allowed as healthcare providers that's really putting us collectively at risk. So we have to be in that position.
Yeah. And just one little point that I want to go back to, because we talked about families that don't overabuse those antibiotics and take better care of themselves. Like saying our family, we, as kids, we really didn't do antibiotics.
Right.
As far as I know, I didn't have a course of antibiotics until I was in college when I had my wisdom teeth removed.
Yeah.
And I have not had a course of antibiotics since. So 50 years of life, and I think I have one course of antibiotics in my whole life.
Do you know I have a child who's never had an antibiotic?
Both of my children haven't. Yeah, so 13 and 18.
How rare this is.
Yeah.
Right.
I have to
How
admit,
about you?
I've only had one antibiotic, and that would have been in my first couple of years of practice. And it came into contact with strep, so we treated the strep. And of course, at that time, my daughter ended up getting it as well, so we treated her. But that was the only antibiotic she had. My son has not had an antibiotic.
Wow.
Okay.
And the
He's 21.
antibiotics really worked well, too, because you didn't abuse them.
Exactly.
Yes.
Took it, and it worked. And yes.
Did you finish the course of therapy?
Yes, it was very easy for me to finish. It was only one day.
Okay. That is easy. That is easy. And what about generationally, where we have a population that's had a lot of antibiotics, so their guts change. And then those people have kids. Don't those kids have different gut flora?
Well, definitely.
And then that gut flora is more delicate, and then we put antibiotics onto that. Is this a concern?
Well, it can be. We get a lot of our gut bacteria from our mothers, and a lot of it is during childbirth.
Okay.
And then we also have a lot more cesarean sections where you don't get that transfer of bacteria as much.
Oh, wow.
So that affects the gut too. And so generationally, yes, that can be more of an issue also.
So then we just see how there's so many things that could be weakening our own immune systems,
Right.
which perhaps are beyond our control, right? Maybe you're someone who's in their 20s or 30s, you've had a lot of antibiotics, you were born via C-section, you have allergies, whatever, or whatever's happened to you, but there's always those things that you can control.
Right.
So yeah. That we always have to remember there's things that we can do.
But with that, I think it is important for people to realize that probiotic supplements, they're a good thing. They can help with those gut bacteria, but all of the probiotic cultures that we get in supplement form don't really colonize the gut and stay there.
I was hoping this would come up at some point because I've
Yeah.
always wondered that. Like, we take them, but how do we know the other guys are letting them in?
Well, but it's the when
Why
you
don't they colonize? Why aren't they accepted? And how do we know like what the right balance is? We don't know enough, right?
Well, there's a lot we need to learn about that, but there's benefits because it helps to normalize the gut, and so the other strains can grow stronger too.
Okay, we know that.
Yes.
All right.
Yes. And so, like, for instance, some of our main gut bacteria are the lactobacillus
Mhm.
and the bifidobacter strains of bacteria. The probiotic supplements that we get are similar to the ones we have in our gut.
Mhm.
So they can help support and help the ones that we already have colonize, grow better, and be stronger so our gut health can be stronger. But we can't look at it in this reductionistic, just like, oh, we do the 3 antibiotics and the antifungal for the infection. It's no big deal. And we just add in some probiotics when we kill all
But
the
this
good
is where
bacteria.
we're going. You realize this is where we're going.
That's why I wanted to bring it up.
Right.
Yeah.
Okay. Yes.
Yeah, so we do have to be careful about that.
Okay. So on that note, then, when you have a patient that is on an antibiotic, would you prescribe a probiotic, and then would you, like, because people ask me, well, my doctor said I have to go get a line, and how do I take it with the antibiotic? If I'm taking a pill of amoxicillin, a pill of a line, won't they be fighting in there? How does that work?
Well, yeah. So, yeah, if we have most of those probiotics, a lot of them can get killed off by the antibiotic.
That's what common sense tells me.
you want to keep it as far away from the
That's
antibiotic
what I
as
tell
possible.
people. Good.
But the other thing is we have other types of probiotics that aren't bacterial. So we have Saccharomyces boulardii, which is a fungal probiotic. So the brand name Florastor, you probably know.
Oh, yes. I've
Yeah.
seen that in the fridge.
Yeah, and so the Florastor is a very expensive brand
Yes,
name
it
versus
sits in the fridge.
you can get Saccharomyces boulardii from a lot of other companies a lot more cost
Did
effectively.
not know that.
Yes, but it's a fungal probiotic, so it won't get killed by the antibiotics. So that's always what I want patients to be taking while they're on an antibiotic. So it'll help to keep that the gut healthier, reduce
During
those
this process.
during that process.
We're just mitigating our risk
right.
of the antibiotic
Yes.
if it's deemed necessary.
Of course.
I love that.
So there was a study that showed that it was like if you take the probiotic 2 hours after the antibiotic, you have a much better
Okay, thank you for that. That's helpful for me to
as
tell
far
people.
as support that way.
Right.
Okay, 2 hours after.
At least 2 hours after, but 2 hours after was one of those ones where they actually did see some benefits. So.
Nice. And it's then you keep the dose standard, because sometimes I just have people take a little bit more, knowing some might get killed. But if I tell them to time it, then okay. I love that. That's a great tip.
Yeah.
And such a really good point about, like, for the people that are more naturally minded to not fall into the same systemic model of a straight line and, well, we'll just do that. Yeah.
Right.
That we all have to, I think, collectively as healthcare practitioners and people, just think a little bit bigger and consider all things.
Right.
And not to panic while doing so.
Of course.
Right.
And also, since we're always trying to be fair on this podcast,
Yes.
sometimes there is a time and a place where you need an antibiotic. And I have patients that I have to talk them into taking their medical doctor's prescription because they really do need an antibiotic
Okay,
at that
I think
time.
that's such a great point. And like for balance, because your patients are more alternative minded.
Correct.
And they're probably more like me, who are absolutely terrified of any and all medication. Like, I love to see it on the shelves.
Yeah.
And I'm just full of joy, but I don't want it anywhere near me.
Right.
So I would be, which is strange, but that fear is not rational either. But if I
Right.
needed it, I would. And I have.
Yeah.
I've done things that I needed to do, but I can see where there would be people with so much distrust
Right.
that they would resist even the thing that would help them.
Right. Yeah. And I would say that more often I'm telling the patients to finish their course of antibiotic that they started.
Good for you.
Versus there's not as many times where we need to, in my practice, I can recommend different natural antibiotics that can take the place, but there's still always a time and a place where somebody needs prescription antibiotic.
Exactly. And yes, I love that because it really is about respecting the chemistry, respecting your practitioner, respecting yourself. And if you're taking someone's advice that you're paying, do so with thoughtfulness and follow through and don't second guess. So what? Whatever happened, and there's always the next day to recover and get better and prevent.
Right.
One of the things that I don't know if you guys have seen, but it's one of the things that I've actually implemented in practice, and I know that there have been some other people that have suggested, I think even studies showing that if you have a patient and you're fearful that they may have a bacterial infection, but you're kind of like, you know what, you're not there yet. Giving a prescription, but saying, don't fill this for 3 to 5 days. And then if you have these symptoms, X, Y, and Z, then fill it and take it. Mm-hmm. A lot of times they don't end up taking it. And that's what the study showed. They don't end up needing it. They don't take it because they waited that time. And so I think you'll see that happening more and more.
I hope so. I think that's genius because it handles the psychological aspect of I came to you and I'm paying for this insurance. And now I'm giving you a copay and you did nothing for me. This piece of paper is not nothing. Yeah. It never was nothing. Even if you get it filled or not, the piece of paper itself has power. It says, I care about you. I'm looking out for you. And in a way, it maybe even has more power. And like, I might not need to use this power, right?
Exactly. Yeah.
I love that.
And
don't until X, Y, Z. And it's very clear cut. So it's not like, well, we hope or we don't know. No, you're telling them because you have spent the time, you've assessed them. And I'm telling you, if it heads here and you'll know if it did for this, Y, and Z, then you fill that. To me, that is such a simple, powerful solution.
I would agree.
And it helps to empower the patient so that they realize, oh, I don't always need an antibiotic and can break that cycle where they're not so fearful of infections.
I love that so much. That is such a great, are we ready to, I love that as an ending to that topic.
I think that's perfect, yes.
And we're going to talk about fevers.
Correct. Something that Mary knows a lot about this week.
I know a lot about. Because in honor of this podcast, when I got very sick this week and my fever was really high, I'm like, nope, I shan't fight this fever. I shall not suppress it. But I don't anyway, because I know that it's helping me. And I'm very fortunate in that when I was a little baby pharmacist, way back, we were dealing with the AIDS epidemic in a real way in healthcare. It was like the end of the 80s and beginning of the 90s. And I was very fortunate to have a very extensive CE that was presented live by a clinician in that field. And they spent all this time teaching us about the immune system, which we didn't know as much before AIDS. We just didn't. And the one thing that I took away, I remembered from that presentation, I know nothing about nothing. I just graduated from pharmacy school. That one of the first things, it sounds so obvious now, but we didn't know that. One of the first things that the body does when it's invaded with anything, an allergen, a virus, or bacteria, is turn up the heat.
Yep.
That's what it does. And I don't think my peers thought much of it. And but I went home thinking, then why do we tell people to take Tylenol? Like, do the good people that make Tylenol know this? That'd be very bad for business. Like that it's something that the body does and it's a good thing. And I just always remembered that.
Right.
And I feel so grateful that I got to learn that.
Yeah. And so basically what the body is doing is trying to increase your body's temperature higher than what that infection can stand so that your body can kill off the infection that way.
Or even keep it from growing.
Right. Right.
Suppress its growth. But yeah, and of course we can talk about numerous other things that the body does whenever you raise its temperature.
Please tell us.
We start to produce more white blood cells, the cells that fight off infection. They become more mobile and able to travel better. So we're putting out other different chemicals that are going to help out as far as killing these different infections. So the fever does have such a benefit that it's important not to suppress completely.
But then how did it get to the point where that is all we do? In fact, it's to the point where the fever is considered a disease itself. And it must be eradicated.
Yes, we need normothermia, where we just have this normal temperature. That's what we're told. You get, not in medicine, just in general as patients, a lot of times. So yeah, make sure you treat that fever. Make sure you treat that fever.
As if it was a disease.
Yes.
Who's their agent? that the fever was marketed, it was a symptom, and now they're graduated to a whole disease in and of itself. How does a symptom go from symptom to disease? Purely and only marketing.
I would agree with you there.
Marketing by the
100%
by the
marketing.
antipyretic
Yes.
drugs.
Exactly. Which I really started to watch those commercials, and it took me years before I realized what they were really selling. And when I realized it, I'm like, that is one of the most powerful marketing campaigns I've ever experienced in my life. Because if you don't give your kid Tylenol, you're a bad mother.
Right.
You're not practicing bad science. You're a bad mother. That is like, nobody wants to be that. So of course I'm going to give my kid a Tylenol.
Right.
It's genius marketing campaign. And okay, so when is, because I feel the resistance coming from all over. Like, when is it? Would it be not the word feasible? When must you reduce a fever?
Well, let's start by defining what a fever
Please.
is, because a lot of people don't even know what a fever is. And they think, they talk about, well, they have a mild fever, but
Or low grade.
Yeah,
I've heard that.
low-grade
Low
fevers.
grade.
And so we're talking about a temperature of 100.4 or greater Fahrenheit. 100.4 Fahrenheit or greater is considered a fever.
Okay.
And of course, we have different ways that we check it too that are also going to affect what we view as far as what the
That's
temperature
very
actually
true.
is.
Different. Yeah.
So, I mean, of course, rectal is going to be, which most people don't do that,
Right.
but rectal is going to be the most accurate because we're getting what the core body temperature is.
Good point.
I'll have to share with you as far as like these different ones where I can shoot my gun and
Yes.
get that over on there.
Which was brought to us by the unprecedented times, right?
Yes,
Right.
Yeah.
exactly.
Yeah.
I saw differences as far as people being outside and coming in. I had a gentleman who was outside. It's really hot outside. He comes in and nothing's going on with him. They check his temperature and it's like 101. I'm like, hold
Oh my
on a second.
goodness.
He's like,
Yeah.
I feel great. Nothing's going on here. I'm like, let me go ahead and check your oral temperature, and checked that. And of course, then it's a normal temperature.
Wow.
So of course, the temperature of the skin based on elements outside
Right.
is also going to affect that.
Yeah. That's
But I
like my oldest, Evan, when he's in bed, he loves to bundle up under the covers.
Yeah.
So when family starts getting sick, because we've all been conditioned now with COVID that you got to check for a fever,
Mhm.
and he'll be so bundled up in the covers that he's got a 104 fever every single time.
Yeah.
And you let him pull the covers off and let him calm down, and it's normal.
So
Dissipate
what
the
about
heat.
the ones you take in the ear? How accurate are those?
Those ones aren't bad. They're about a
Yeah.
degree less than what it actually is. So we're like 1 degree Fahrenheit less.
Okay.
And that's the thing. All of an old style mercury or non-mercury thermometer in the mouth is going to be a lot more accurate than the digital one in the mouth, or
digital,
the ear,
yeah.
or the
The
forehead.
digital mouth
Right.
ones aren't accurate?
They typically aren't as accurate.
So anything...
But I'm sure it depends on
The actual
you know,
brand. Or,
the brand. Say in a doctor's office, it's going to be a lot more accurate than the
Of course.
$2.99 one you buy in the drugstore.
So then what is considered a high fever?
so that's a difficult question
Depends on
to
adults
answer.
and kids, right?
It just in general, we start to talk about a fever, and I would say 104 and greater is where usually we're starting to say, okay, that's a very high fever. And I know a lot of people have a lot less tolerance, but I think as far as if we're actually looking at it, 104 and greater is what would be
I think
considered
that's where
a
I
high
was
fever.
this week. Yeah. High.
Yeah, and when you get to that high, yes, you're uncomfortable, and
But will you die from it?
well, of course not. But that's where you get to that degree, and it's okay to take lukewarm baths or things like that to help make you more comfortable and calm it down a little bit.
All right. What about I have a high fever, so if my kid has a high fever, they'll get a seizure.
Yeah, that's definitely a difficult one because I know that that's perpetuated out there, and that's one of the biggest reasons that we treat any temperature and trying to get to that normal temperature is because people are fearful of that. With a normal fever, even a high fever, we typically don't see a seizure occur. It's whenever we have hyperthermia. We are not sweating. We're holding in the heat. We're dry. We're hot, dehydrated. Those are the times that we can end up seeing that. And, usually this is going to be at the very onset of a fever, not as the fever is progressing.
Interesting.
And so that's where we're looking at that.
But it also can depend on how quickly the fever rises too.
That is true.
Oh, so if it rises really quick, maybe the body doesn't, the nervous system can't adjust, and then you might get a seizure.
Right.
Well, what about if you're constantly, if you have a really high fever, but you give Tylenol or ibuprofen, whatever, comes down, but then it wears off and it goes back up. And then will the up and down cause any seizure potential?
I haven't seen that. I don't believe so. I can't speak that there's any studies on that, but I don't believe that that's the case at all.
It's just a really high fever with the other things that would be going on, the dehydration and the lack of sweating.
It's going to be a slow reduction with the Tylenol or Advil or whatever, and probably a slow increase again as the medication wears off.
So what are the risks of treating a fever with Tylenol, ibuprofen, or something like that? If we're looking at that, we're suppressing the body's immune system from being able to fight things off. We can reduce the time to diagnosis of a more serious infection, and then toxicity. Those are the big things that I would think about.
Right.
I like what you're saying about reducing the time, because I would always tell people, since I got in community pharmacy, just because of my background with alternative medicine, well, I'm sick, I can't get into the doctor. Should I take some Tylenol or ibuprofen? I'm like, well, then you're really not going to you're not going to know what to tell them.
Right.
What do you mean? I said, if you artificially do something to yourself, you're not going to have good information for your doctor. So I've always said that. So I'm glad you're kind of validating that you want a clear picture of your own clinical case.
Right. Yeah. And so the benefits of treating the fever is if somebody does have a higher fever, a child, and they're very uncomfortable. And usually it's because of they're very uncomfortable, a lot of pain or the headache, those types of things.
Yes.
And those can be times of benefit where you're like, okay, I'm going to help.
Agreed.
But again, not just to say, I need to get them to a normal temperature.
Right.
Right.
One of the things I wanted to ask, because a lot of times I do some natural things to try and help out with fevers, is your thoughts on that as well. Because, so say, I remember before I was a medical student, I practiced reflexology. And so I remember specifically, I had a family invited me over because their son had 103 fever. And I'm working on his feet. And of course, one of the areas you can work on is over on the big toe, the great toe. You have the pituitary and hypothalamus reflex. The hypothalamus is where we kind of control our temperature. And so this particular reflex, I worked it, and I was able to get his temperature down within like 2 minutes. Then the kid's up and running around and having fun and playing. Or giving a homeopathic, sometimes Ferrum Phos, or is something to that effect, or again, the tepid baths. But what about using those? Do you have any issues with using those to help get down?
Because again, you've then technically
are we suppressing?
Yes.
Or are we augmenting the body and how it's responding?
Like with the homeopathics, it's going to
Which we don't talk about on this show.
But it's going to be speeding up the recovery time for your body to fight the infection.
I would agree.
Yeah.
Okay.
So that benefit, because you're strengthening the life force.
Right.
But it's such an interesting point about reflexology.
Yeah.
But reflexology takes into consideration the entirety of the body.
And with that child, did it wear off and the infection get worse again? That would be my one thing to look at, is if maybe that did just stimulate his immune system, things calmed down, and his body took over and just moved on.
You know what, for that particular one, from what I remember, and of course I worked the whole foot as well and worked in any areas that were off, but that was the one specific thing I did to try and help out with the fever. And he was up and playing around after that, and Mom said he recovered very fast, like the next day or so.
So I would say that it was probably the totality of the therapy that just helped him get over that hump with the infection.
Exactly.
Which is such a great point, because no drug can offer totality in therapy.
Right.
Right. Where something like reflexology can. Not to say one's better than the other, but I think it's just a really interesting distinction.
Yes.
Because a fever is not existing for no reason whatsoever. It's part of who knows what else we'll discover about it, right? Down the road. We knew so little, and now we find out more and more. But the fact that it does show up and does all of these things, or help the body with all of these other things, getting rid of the thing that doesn't belong there and enhancing the things that do belong there.
Yes.
Respect. I'm so glad I had a fever of 112 and I just live to tell the tale. No, it is the pain that's so, when the fever's so high, it hurts so bad. And there's really, I've looked and said, well, okay, if I just kill it for one night, but I did recover so fast. And I think that had a lot to, I'm willing to, I guess for me personally, and it's just me, it's my body, my choice. I'm willing to suffer really hard for a short time to get better. Like I'm willing to feel bad now to get better later.
Right.
And that's the opposite of what we're taught, I think, marketing wise in the American healthcare system. You must feel better at all costs.
Right.
You must feel better at the cost of getting better.
Right.
I think that's
For long-term health.
Yes.
right.
I would agree.
That is dangerous
Short-term.
messaging, in my
Right,
opinion.
right.
There's definitely a balance.
Now, as far as temperature-wise, what would you say you'd be worried about with a patient if the fever got too high?
So I'm telling parents if their child's going over 104, go ahead and treat it to go ahead and bring it down. That's typically for a child. And just part of it's, again, that comfort thing for the child because they're usually very uncomfortable. That's typically what I say. If we're talking about when you're supposed to, I think it's the one Journal of Pediatrics that I looked at, the article said a temperature over 101 is what they recommended.
Oh, wow.
So, but those were the different things that I had looked at.
And then as far as how long would you want to treat that fever before you seek help?
Yeah, so I guess it's going to be taking a look at the other symptoms as well.
Right.
Always looking at and seeing, okay, are we having a lot of pain? Is there headaches? Whenever we have that fever, there is some process going on in the body. Are we having a cough that's with it? And this patient looks like they are very sick. They're not breathing well. Or are they having a lot of pain? They're having discharge from their ear. They have a ruptured eardrum. Or so we're looking at everything else and taking it in. It's, again, not all about the fever.
Right. Yeah. So, are they really listless and barely moving?
Yeah. Yes. So those are the times. And yeah, I've had patients like that where the parents, they have brought him into the office and they said, yeah, this kid is just laying there. He's not even moving. He's not doing anything. And they have a high temperature. Then I'd say, yes, treat them. Let's get them hydrated then, because right now they're not doing what they need to drink. A lot of times you'll see with kids, they'll refuse to drink whenever their fever is extremely high.
I wonder why that is. You would think with everything burning that you would want the water to cool it down. Like, why is that set up that way?
Is it just an irritation? You're more miserable at that point in time and you just don't want to be bothered? Or I've seen that with some kids and they'll refuse anything at that time because they're uncomfortable. Or with somebody who can't talk as well, do they have a sore throat?
Yeah.
And I don't want it's irritating to my throat whenever I go ahead and I swallow.
Yeah, that brings up a point like temperament. People have different temperaments when they're sick, right? And the part that the allopathic system doesn't treat, and the system that we don't talk about does treat, is the temperament of the patient when they're sick. Because all of you is affected. Your emotions, your cravings, your whatever. Yeah.
That sounds like homeopathy.
No, we don't talk about that. But it does. It's just really it's interesting to me too. One of the best examples I have of that, one day I was really sick many years ago, just so sick, the fever, the whole thing. And I had a really intense fear that I was going to be taken. And I was so fearful that I was going to be taken that I almost couldn't speak, that if I spoke of it, right? And nobody talks about that when it comes to sickness. Like, well, what are you afraid of? But the homeopaths too, like, well, what are you afraid of? I'm going to be taken. Thank goodness that's normalized, or no one would ever speak of it. And then the one remedy was not, because homeopathy doesn't treat symptoms, but like that, there was something about fear being taken, and that's what was suggested and I took, and I felt amazing after that. And I always look at, when I would consult the homeopath, like what's their temperament was always the question. And then I always became curious about the different patients and how people really do change when they're overcome with something.
Yes.
Right. And like the times I've had a bacterial infection, my temperament is very different than a virus. A virus always feels very dark to me, and I go to very dark places when a virus is present in my body, and it's just like that's just a different way to look at yourself overall when you're not feeling well. All of you's not feeling well.
Right.
Like some people feel so bad they don't want any help. That becomes part of their case or being, right? I just stay away from me. Like everyone stay away from me.
Right.
Hard to help people like that, right?
Right. But I think it also comes down to your mindset too.
Which is affected. For me, my mindset was affected by that virus, let me tell you.
Right.
Yeah, my mind is a very positive, strong mind. This week, it was anything but.
Right.
That is frightening because that's one thing I count on.
Right. And that's what we've talked about before. You're scared of being sick.
Very scared of being sick because I will be taken, Ted.
Right. Right.
That is terrifying.
Right. Where we grew up not being so afraid of that. So for me, I get sick. It's an annoyance that I have to stop working. I have to do different things I guess I should take those extra supplements to try to get better quicker so that I can get back to work quicker. Yes. It's not a worry about that infection is going to harm me.
Not the infection that's going to hurt me. It's the people that take me.
The people going to take you to the loony bin.
Wherever they're taking me. I don't know. Because if I'm sick, I'm weak. And if I'm weak, I'm vulnerable. And if you're vulnerable, you get taken.
Got it.
That's just,
okay.
What else do we want to say about fevers? Oh, I looked up the sales of acetaminophen. Oh my goodness. The sales of acetaminophen in this country. Yeah. I wonder if we have data on sales of acetaminophen in socialized medicine countries. I don't know that they keep track of it. We keep track of our sales of everything in this country because our system is based on capitalism. And I don't know that they have to keep track of sales if your system is based on...
But that's the thing. People don't take Tylenol or acetaminophen just for a fever. That's a benefit. That's a side effect. It's more for people focus on the pain and everything else.
That's true. We take it a lot.
Right.
We do like our pills.
Definitely.
We do. We like to do that. And again, a fever we all agree it's a symptom, right?
Correct.
Did pain go back to being a symptom? Remember when pain was a symptom and then it was a disease so that we could give people opioids and then we realized that was a huge mistake. So did it go back to being a symptom?
It used to be called one of the vital signs.
Oh,
it turned into back whenever we had the opioid epidemic.
Oh, I know. I was practicing then.
Yeah. So no, I think it's back to a symptom.
Isn't that amazing? But a fever is not a disease yet.
It is not. It's
okay. All right. It's still a symptom.
But so obviously we were talking about that marketing. So it depends if something's a disease or a symptom depends on how good of medications you have to treat it.
Of course.
So the opiates, so pain is a symptom now because we don't have the opiates to save the day.
Right. Well, we did, and we still would.
Right.
Had it not been for all of the horrible things that came from that.
Yeah.
So I hope that a fever remains a symptom. And that we put it in its proper place and give the body its proper respect, just like we would give an antibiotic its proper respect or an antipyretic, something that fights a fever, its proper respect. Everything just has to be given respect. And we should tell the truth about what things are.
Right.
We should tell the truth. An antibiotic does not kill a virus.
Correct.
And a fever is a symptom and it has a purpose in the body. That's all, really, all I want is a little more truth and a little less marketing. I'd be very happy with that.
Definitely.
Not all of it. I'm a realist. We're not going to get rid of all of marketing in medicine.
Right.
But I would like a little more truth. That's all I want.
All right.
Anything else we'd like to say or sum up about that?
No, I think that's good, but I think that we should talk about thank Dr. Suzelis, Dr. Ian Suzelis, my brother.
Yes, we should.
And we really didn't announce that earlier, I guess. That
we will, though.
Yeah,
when we do the intro.
But that my brother and but we really enjoyed you on this podcast. And we were hoping to have you back very soon so that we can talk more about some of these conventional medical treatments that we should be looking at differently. And yeah, we're hoping to do our next one on dietary therapies and dietary recommendations that doctors make that are totally wrong.
Oh,
Thank
that
you
would be
very
a
much for
good
having me.
topic.
Yeah.
That'd be a really good topic.
Yeah,
But
that'll be a lot of fun.
yeah, I loved your perspective, and I've learned so much from you, and that you practice every day. You're in the field every day. You're a clinician. Yeah, and it was just great having you. You guys are two Suzelises in one room. Amazing. And is that what compelled you to do this today, Ian, to help out Ted, or do you like this topic? I know you're very into, I know you care so much about your patients. That's why my kids are your patients.
Yeah. No, I actually just thought this would be something very enjoyable to do, just to be able to get together and share as far as just the information you have. I think it's so important to share the information.
Yes. Oh, we
And
do
so,
too.
yeah.
Yes.
I enjoy learning from my brother. I learn from him all the time and always have questions for him. And so,
Oh, I love that.
Yeah,
That's just
it's
so
a good
great.
back and forth.
yeah.
Yeah.
And that's where if patients, when they find out that my brother's a primary care doctor, well, do you guys have big arguments? Well, no, we respect each other and we learn from each other, and it makes both of our practices better.
Imagine that.
Yeah.
We could just spread that around along with the truth.
Right,
Yes,
right,
I love
right.
that.
It's funny
I love
because I had
that.
the same thing happen yesterday. Somebody was asking me, so what do you have going on tomorrow? I said, so I'm going to do a podcast with my brother. He's a naturopathic physician. Oh, so is this going to be a really high tension discussion?
Gosh.
I'm like, well, no, not really. I think we have along the same lines. I said, I'm more of that bridge in between the conventional and the alternative, just trying to balance that part out. But,
Right.
So
Where in a lot of ways, I have to do the same.
exactly. Yeah.
And I just give drugs.
Keep those prescriptions coming in to pay your paycheck.
Keep them coming. Keep them going. Yep.
All right. I think we're done.
Yeah, that was so good.
Take on Healthcare was created and is hosted by Ted Suzelis and Mary Sheehan. The information contained in this podcast is provided for informational purposes only and is not intended for the purpose of diagnosing, treating, curing, or preventing any disease. Before using any products referenced on the podcast, consult with your healthcare provider. Carefully read all labels and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Mary Sheehan and Ted Suzelis, disclaim responsibility for any possible adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations for warranties about guest qualifications or credibility.